looking at what we've just said, we see that we are not treating only the patient that need the treatment. Some patients will recur despite the adjuvant chemotherapy, and some patients are already cured before starting chemotherapy. So how to find the good ones? So first, we can have a prognostic tool or we can have a predictive tool. A prognostic tools mean that you know that in this group, 100% of patients or almost 100% will be cured with surgery. So in this case, probably it's not necessary to perform any adjuvant chemotherapy. At the opposite, you may have patients that will recur in 100% with a very severe prognosis, and that may better benefit from chemotherapy, even if it's not the case in all patients, because we know that some patients resist also to chemotherapy. So one new tool is circulating tumor DNA. This is something possible since around 10 years, because we are able now to find one strand of DNA circulating in the blood of the patient out of 200,000 strands of normal DNA. Before, we were not able to go so in depth in the analysis of circulating DNA. So we are able to identify one strand of tumor DNA. And if we find a tumor DNA, it means that there is tumor cell somewhere in the organism of the patient. So it may show us what we call patients with a molecular residual disease or minimal residual disease. The acronym is always MRD. And in this case, we can say that patients that have that will probably recur much more than the other, and patients not having that will probably recur less often, and maybe can be we can avoid chemotherapy for those patients. So this is the theory. We had very nice papers showing more or less this kind of results, initially published by different teams around the world with different techniques. But the problem is that these papers were with a very few number of patients with positive ctDNA. It was generally between 10 and 20 patients, which is super low in the field of adjuvant colon cancer. In our trial, for example, we always have more than 1,000 patients and sometimes more than 3,000 patients to decide. So having only a group of 14 patients to conclude is not enough. So there is still doubt about what is the best technique, what is the best timing, and what is the real value of this approach.